We're just connected right now. We're waiting for our Director General, Dr. Tedros, to arrive. But in the meantime, what we'd like to do is we'd like to hear from you. We'd like to know who is connected here. Please do use the link. We are posting a Slido link. Please do use that to let us know where you are joining from and your name. So if you can have a look. Please go on slido.com with the password hashtag WTBD, which stands for World TB Day 2024, or you can use the QR code to scan. Please tell us your name and where you're from. So let's start with this while we wait for our Director General to arrive and the moderator, Dr. Teresa Kasayeva. Okay, so we have several hundred people connected. Please do share your name and where you're from as we wait to begin the talk show. Great, so we have Salman from India connected from IFMSA. Okay, Kerry from the UK. Please do share because it's great. We always have hundreds of people joining these events, and we'd very much like to know where you're joining us from and have your active participation through this event. All right, dear colleagues, thank you for joining us both in person as well as online and for sharing your names and the countries. We will save this and share this widely as a screenshot. So now let's commence the talk show. And for this, I hand over to the director of WHO's Global TB Program, Dr. Teresa Kasayeva.
Thank you very much, Monica. Dear distinguished colleagues, partners, and friends, I'm Teresa Kasayeva, Director of WHO Global Tuberculosis Program, and I'm very excited and pleased to welcome you to this important online talk show to commemorate World TB Day. We are organizing this annual event on World TB Day for over 5 years. This year, World Tuberculosis Day is being commemorated under the theme, Yes, We Can End TB. We would like to convey our message of hope that we all together can get back on track to turn the tide against the TB epidemic and to reach our ambitious targets with global and regional country leadership, increased investments, faster uptake of new WHO recommendations, adoption of innovations, and multi-sectoral collaboration to combat the TB epidemic. I'm very pleased to highlight that there have been several positive developments around World TB Day this year. Today, Dr. Tedros Adhanom Ghebreyesus, our Director General, will officially launch the WHO investment case on TB screening and preventive treatment, developed with the support from UNITAID and FIND. We had also excellent, inspiring news of increased investments from USAID in collaboration with celebrity and philanthropist John Green. Later this week, WHO will be releasing also new guidance on the use of the targeted next-generation sequencing tests for the diagnosis of drug-resistant tuberculosis, along with the WHO TB sequencing portal. The M72 promising TB vaccine candidate, that is the only one, the most promising vaccine that reached the threshold of 50% efficacy, the target in WHO's target product profile, has just commenced phase 3 trials this week. And we have also seen over the past few weeks excellent campaigns led by WHO, country offices, national TB programs, partners with engagement of youth, societies, communities to spread awareness and action on ending TB. You will see a few examples from Pakistan and Nepal. We've seen recently amazing activities in Philippines. Stop TB Partnership is leading advocacy in the regions. So we are very inspired by this growing movement and advocacy. Dear colleagues, as I've told, we have very rich agenda today with a lot of important news and releases. And I welcome our distinguished lineup of speakers today. They are all powerful voices for the fight to end TB, include TB survivors and advocates, first of all, civil society, honorable ministers of health, ambassadors, heads of agencies, partners, and of course, WHO leadership and colleagues across all 3 levels. We plan to have a very interactive format. We see growing number of people joining us. Traditionally, we have hundreds of people joining. Hope today will be the same. If you have questions, please put these questions into the Q&A section. Following presentations, we will have this interactive Slido exercise where the audience will have opportunity to share your vision on the priorities, the most important activities that should be undertaken. They will be all carefully analyzed and then later on uptaken and taken into consideration. This talk show is being also streamed on YouTube, our WHO platform and TB forum, and we urge our members also post your reflections and hope that this talk show will reach thousands of people at the end. To start our talk show, I am very honored to welcome our Director General, Dr. Tedros Adhanom Ghebreyesus, who will open the talk show with his address. Dr. Tedros, please, floor is yours.
Thank you. Thank you, Teresa. And thank you also our ADG, Jerome Solomon, honorable ministers, distinguished guests, dear colleagues and friends. Good afternoon, and thank you all for joining us today. World Tuberculosis Day this Sunday is an opportunity to remember, to honor, to thank, and to commit. We remember the millions of people who lost their lives to TB every year, and the millions who continue to struggle daily against this preventable and curable disease. We honor the health workers at the forefront of the fight to end TB. We thank the communities, civil society organizations, advocates, partners, and donors for their tireless dedication and support. And we commit to carry forward the fight to end TB, which remains one of the world's deadliest infectious diseases. Each day, TB kills over 3,500 people, and the disease strikes close to 30,000 more. It takes an enormous human and social toll on those affected, their families, and communities. Poverty, inequality, malnutrition, comorbidities, discrimination, and stigma are major drivers of the TB epidemic. In the political declaration of the second UN high-level meeting on TB last year, world leaders committed to concrete targets over the next 4 years to reach 90% of people in need with TB prevention and care services, to use a WHO-recommended rapid test as the first method of diagnosis, to ensure that all people with TB have access to a health and social benefit package, to develop at least one new TB vaccine that's safe and effective, and to close funding gaps for TB implementation and research. If 2023 was a year of commitment, then 2024 must be a year of action to implement those commitments and ensure millions of people benefit from life-saving services for TB prevention and care. We build on a strong foundation. Global efforts to combat TB have saved an estimated 75 million lives since the year 2000. And we're seeing some positive trends. Last year, we saw a significant increase in access to services for diagnosis and treatment, the highest number of people diagnosed since WHO began global TB monitoring in 1995. There is also some progress in the development of new TB diagnostics, drugs, and vaccines. Last year, I launched the TB Vaccine Accelerator Council to support innovative sustainable financing, market solutions, and partnerships for TB vaccine research. WHO is also working closely with countries to support the adoption of the multi-sectoral accountability framework, recognizing that ending TB will not be achieved by the health sector alone, but must involve all sectors and communities. And to that end, we continue to listen to the voices of affected communities through the WHO Civil Society Task Force. I am pleased that Ashna Ashesh, a survivor of MDR-TB and a new member of the task force, is here with us today. However, all of this progress is constrained by limited funding. So today, I'm pleased to launch a new WHO investment case for TB to help countries advocate for more resources to close gaps in access to services for prevention and care. The investment case outlines the health and economic rationale for investing in evidence-based, WHO-recommended interventions as part of every country's journey towards universal health coverage. Let me leave you with 3 priorities for the year ahead. First, for governments to show leadership to translate last year's high-level commitments into action. Second, for donors to invest in rolling out WHO-recommended preventive treatment options, shorter treatment regimes, and rapid molecular diagnostics and tests. And third, for all of us to take action to address inequalities, stigma, and discrimination. Thank you all for your continued leadership and partnership. And TB, yes, we can. And finally, I would like to thank Ms. Amy Pope, Director General, International Organization for Migration, for joining us. And thank you so much indeed for your leadership. And thank you to all partners, especially UNITAID and FIND. I thank you.
Thank you very much, Dr. Tedros, for your inspiring opening. This is our new tool that we hope will be extremely useful. Thank you for launching it. Thank you for your leadership and support. Dr. Jerome joining us for launch of this tool.
Thank you.
Yes, we can.
Thank you. Yes, we can.
Dear colleagues, now I'm very pleased to have with us Ms. Ashna Ashesh, a survivor of multi-drug resistant TB, a lawyer, public health professional, member of WHO Civil Society Task Force, and vice chair of the Southeast Asian region STAC TB. She is also associated with the community collective Survivors Against TB and advocates for person-centered TB care. Ashna will share her story and calls for action.
Thank you. It's such an honor to be here. Am I audible to everybody? Yeah. Okay. Thank you so much. So I'm going to keep this short. I'm going to briefly talk about my story, and then both from a survival-affected community and a public health professional perspective, talk about the key things we can do under each step in the TB care cascade. I was diagnosed with TB in 2017, and due to the lack of effective screening and incorrect treatment, my disease progressed. And in a few months, we found out that I had multi-drug resistant tuberculosis. And this was after my insistence. My doctor was still willing to wait. My initial doctor was still willing to wait for a few months and see how it goes. But because I worked in public health, I knew something was off, and I pushed for a referral, and that's where I got a proper diagnosis, and my treatment started from there. MDR TB treatment goes on for 2 years. The longer regimens, I'm talking about the longer regimens because that's what I was put on. This is not the all-oral regimen. This has 6 months of injections in it. And by the end of those 6 months, when we were nearing the end, we almost ran out of places to inject me because these are intramuscular injections. They can only be given at a few specific sites. So in addition to that, the treatment for MDR-TB, the longer regimens, they tend to have various side effects. There's the possibility of hearing loss, possibility of vision loss. It affects your kidney, liver, affects your digestion, has various mental health side effects ranging from mood swings to depression, anxiety, suicidal thoughts. And it's the longer regimen is by all means a medieval treatment that we still are in the process of phasing it out is very good, but we can't phase it out fast enough. I mean, we needed to have done it yesterday. And I'm glad that now we're moving towards shorter all-oral regimens. But briefly, that is my story. And I was, despite what I went through in those 2 years, I count myself as lucky because one, I survived. And interestingly, that's how I came to work in TB. So 2019, I completed my treatment. And a couple of months later, I started working in TB, both with the lived experience of a survivor and a public health professional. But as the Honorable Director General mentioned, we have lost lives to this preventable and curable disease. And any life lost to TB is not inevitable, it's preventable, right? So what can we do as we build on the progress and momentum that we already have in place? To begin with, any intervention needs to be informed by these 4 things at any step in the TB care cascade. So it has to be a rights-based approach to care. It has to be grounded in the belief and the understanding that health is a human right. And that's what we are facilitating for affected communities. It has to be gender responsive. It has to factor in that while, yes, TB can happen to anyone who breathes, and it does affect people of all genders, caste, color, creed, disability, sexual orientation. But the social vulnerabilities for different groups are different. And when it comes to gender responsive care, we have to factor in that each gender, each sexual identity or person with different sexual orientation would have varying needs and varying vulnerabilities. And care as such has to be gender responsive and LGBTQIA++ affirmative. Then we move on to something that's the bedrock, actually, of all of the work that we're doing in TB elimination, which is meaningful community engagement, meaningfully engaging affected communities and civil society. What I mean when I say this is engaging affected communities and civil society as co-creators and sort of equal stakeholders in the design and the implementation of TB care policy frameworks. And I'm going to get to the specifics of this in a bit when I talk about the interventions that we need. And the last, given the times we live in, the last thing that all of our interventions need to be informed by is future preparedness, whether it's the pandemic, whether it's climate change, whether it's the wars in this case that we're currently witnessing. TB programs and actually any disease program needs to factor in and be prepared for such events, because moving forward, we are going to face more disruptions. And every generation has faced that. I don't mean to be a doomsday prophesizer. I mean, every generation has gone through their share of problems, but ours are unique to us, and we need to be prepared to face them head on. It can't be a post-facto approach where we end up putting a Band-Aid on a bullet wound. So with these 4 things in mind, I want to move to the specific interventions under the different elements of the care cascade of TB. To begin with prevention, and what I want to say here, and I was at the press conference with Dr. Kaseva yesterday, so I'm just going to quickly recap what I did for prevention and screening there, which is that in prevention, we need to look at it as a complex set of factors. TPT and vaccines are a very important part of the story. But beyond those factors, we have to look at social protection, because undernutrition, lack of safe housing, overcrowded spaces are all things that put people at a high risk for TB. We need to factor in climate change into TB prevention, because climate change is very closely linked to impacting food security and housing for people. The same goes for war, right? When war comes into play, basics tend to go out the window, and be it preventive care or curative interventions, those become inaccessible. So when we look at prevention, we need to address this complex web of factors and then make our interventions and strategy. When it comes to screening, it has to be available, accessible, affordable, and high quality. What I mean when I say this, I'm going to give you an example from my context. I'm from India, and while we're a country with limited resources and we're doing our best to meet our goals of eliminating TB, we do have constraints. We're a huge country with a huge population, and we're scaling up to making sure that they have testing adequately accessible to them. But what ends up happening is in provinces, either the tier 1 or the tier 2 cities will have 4 or 5 centers, and then the entire province's burden will fall there because people have to travel there to get tested, right? So it has to be accessible in that sense that every district, every village, whatever unit, local unit you have in your country needs to have a testing center with equipment and qualified lab personnel. The second thing in terms of accessibility is also we don't factor in sometimes that for informal sector workers or for blue collar jobs, a lot of times getting tested in the day is not an option. They only maybe get off in the evenings, or they have a night shift and they can only do the day. So keeping that flexibility where testing centers remain open with these flexible time slots, or we provide mobile screening where we go to their work sites and ensure they can get tested. All of those things need to come in. Again, accessibility is also social. So you have to ensure that there is a lack of discrimination in the provision of these services. And it's economic, of course. You have to ensure that this is affordable. So when you move on to treatment, once you've screened someone and if they have active TB and we're looking at treatment, we have to move to shorter all-oral regimens. The long regimens for TB, and I can speak from personal experience, are brutal. They affect, even if you survive it, they still have lasting side effects once you've successfully completed treatment. And in this day and age, when we've made the kind of advances that we have made in modern science, nobody should have to go through that treatment. We should move to shorter all-oral regimens immediately, as soon as we can. In terms of treatment, we also need to look at it more holistically and factor in that while dealing with the clinical aspect is very important, we're not treating the bacteria, we're treating a person. And the person lives in a particular context, which is informed by sociocultural barriers. Their access to treatment is often mediated by these barriers. So providing care that is culturally competent, providing treatment regimens that are attentive to that local context and that person's reality becomes incredibly important. Providing them support at every step becomes incredibly important. Because this is, with 2 weeks of COVID, where we had to isolate for 2 weeks initially during the first lockdown, we all know how stifling it felt. This is, with TB, it's anywhere from 6 months to 2 years. That's a long time to be dealing with this. And you need constant reinforcement and support throughout the process. And then, of course, when we talk about TB and comorbidities, when we come to the treatment or the testing, we talk about diabetes and HIV, but we don't talk about mental health enough. And TB and TB treatment both have catastrophic mental health consequences. And we need to address those, not just from the perspective of a person being able to complete their treatment, but from a quality of life perspective. Because at the end of the day, we're all here so that people can live a better quality of life, not just so they can mark a checkbox that they have finished this medication for 2 years, right? So providing mental health support and mental health screening, the way we do for diabetes, the way we did for HIV, the way we did bidirectional screening for COVID, we need to start doing that for TB and mental health. Because not only does TB and TB treatment affect mental health in turn can also be a risk factor for TB, because people with mental health often may not have access to adequate nutrition, housing, they may not be able to hold down stable jobs. And this is not the case for everyone, so we can't extrapolate this to everyone with a mental health issue, but they are more vulnerable to these things given the stigma around mental health. And add TB to that, that is a dual layer of stigma. In terms of our future preparedness, again, what that would look like in very tangible terms. For instance, with the pandemic, what we saw in the beginning of the COVID pandemic, the collective I'm associated with, Survivors Against TB, would get calls from people saying, we don't have meds available, they're stocked out. So planning stocking in advance, stocking for a few months in advance, keeping buffer stocks. That's one way to look at dealing with an oncoming pandemic where you could have stockouts. Factoring in climate change into TB care and policy, factoring that into how, when you're implementing things, that would change or that needs to shift. And when it comes to war, making sure we have enough emergency preparedness in place, whether that's through international law, negotiations, diplomacy, whatever tools we have at our disposal, and using all of them to make sure that basic care can go through to the regions that need it. And I'm going to tie this up by coming back to the bedrock of TB elimination efforts and say that whether it was putting a man on the moon or eliminating TB, no one person can do this alone. We have to harness the power of the collective. And the power of the collective lies in affected communities, civil society organizations. And by collectives, I don't just mean TB survivors or their communities. I mean every collective, collectives of public health professionals, collectives of scientists, collectives of affected communities. That's where we're going to find the power to actually work towards eliminating this. So thank you so much. And I look forward to the panel discussion.
Ashna, thank you very much for your strong and really professional voice. We're proud to have you with us. Thank you for collaboration. And now I would like, with the great pleasure, introduce our next speaker and a statement from Honorable Krzysztof Zgrzewski, Permanent Representative of Poland to the UN. He is a co-chair of the newly formed UN Alliance of Countries on the Fight Against Tuberculosis in New York.
Excellencies, distinguished guests, dear colleagues and friends, it is my great pleasure to address you today on the occasion of the World TB Day. I wish to thank the World Health Organization for its leadership in commemorating this important day. I am very glad that we all gathered here to reaffirm our collective commitment to end TB. Excellencies, we are at the important moment for the global fight against tuberculosis. Just 6 months ago, we gathered in New York for the high-level meeting on the fight against TB, where we agreed on new and ambitious commitments for the years ahead. I was honored to co-facilitate the intergovernmental process that led to this meeting. The political declaration adopted at the high-level meeting constitutes an important roadmap of action. It contains the most ambitious targets to date in the fight against TB. Among these, Member States committed to reach the target of covering 90% of people by TB prevention and care services. Governments also agreed to take the necessary steps to close the deadly gaps in diagnosing and treating TB in children. Moreover, the declaration contains for the first time commitment to develop new effective vaccine against tuberculosis within the next 5 years. Now we need all hands on deck to make the vision of ending TB a reality. It will be crucial to have coherent and coordinated approach to follow up on the implementation of the historical political declaration. Concerted action is needed across the health and other sectors to address the social, environmental, and economic determinants of TB. In order to step up political commitment to end TB, the Alliance of Countries on the Fight Against Tuberculosis has been established in New York, and that's a very good news, in September 2023. It is co-chaired by Indonesia, Nigeria, the Philippines, and Poland. So far, 24 countries representing all regional groups have joined the alliance. It was created as a grouping of countries that are high burden to tuberculosis infections and countries who commit to support the fight against tuberculosis. It is aimed to initiate activities that are highly relevant to build awareness, maintain focus, and encourage concrete measures to fight against tuberculosis. We look forward to working together with the Member States to maintain great visibility of the issue at the United Nations in New York. Excellencies, too many people around the world continue to suffer from tuberculosis. We must keep the momentum going to stop the spread of this ancient and deadly disease. In order to do so, we need to act together and increase our commitment to prove that, as it is highlighted in this year's Spotlight, yes, we can end TB. Together, we can turn the vision of a world free from tuberculosis into a reality. And I thank you.
We also would like to thank His Excellency Ambassador Krzeski, Government of Poland and Uzbekistan, co-facilitators of the second high-level meeting on TB, for their continued leadership. It's extremely important when not only high TB burden countries, but low burden countries continuing fight and focusing on TB. This brings us hopes that we can really succeed. With this, dear colleagues, I would like to move to our move according to our agenda to the next session. And here we will have high-level representatives from high-burden countries, our key stakeholders and partners, and to share their views and the latest news about putting our strong, ambitious commitments and targets from the high-level meeting into the concrete actions to move NTB agenda. And our first speaker at the first panel will be His Excellency Mr. Upendra Yadav, Deputy Prime Minister and Minister for Health and Population in Nepal.
Honorable Ministers of Health, WHO Director General, Regional Director, WHO CRO, esteemed leaders from the global TB community, guests and participants. It is an honor to address this esteemed gathering on behalf of the Government of Nepal as we come together to mark the World TB Day and discuss the imperative of translating the UN high-level meeting into a tangible actions. As one of the 30 high-burden countries for drug-resistant TB, Nepal is fully aware of the gravity of this challenge and has already undertaken substantial measures to address this. Despite the challenges, we stand resolute to ending TB from Nepal. Recently, we have updated our National Strategic Plan for ending TB 2021 to 2026, aligning with the UNHLM commitments and prioritizing patient-centered services. This strategic plan serves as a foundation for evidence-based advocacy to mobilize domestic and international resources for comprehensive efforts to TB elimination in Nepal. The TB Free Initiative, launched in late 2021, is another cornerstone for TB response in Nepal. Initially introduced in 25 out of 753 municipalities in Nepal, the program has expanded to an additional 100 municipalities this year. This flagship initiative focused on early diagnosis, prompt treatment, initiation, and completion, while also reaching undeserved communities and ensuring equitable access to TB care across the nation through community engagement and multi-sectoral participation. By empowering local governments and communities, this initiative fosters ownership, accountability, and localized solutions to address TB challenges. Recognizing the significant challenges of missing TB cases, accounting for over 45% of esteemed cases in country, we are actively engaging private providers, communities, and employing sensitive tools for TB screening. Adhering to WHO recommendation, we are also expanding the TB diagnostic networks and deploying innovative strategies to close the gap on missing TB cases. Nepal is actively transitioning towards utilizing all oral treatment regimes for drugs resistant TB, a significant step forward for improved patient adherence, reduced treatment burden, and better health outcomes. By 2026, we aim to enroll all eligible DRTB patients into the oral treatment regime. To provide comprehensive support, Nepal has been offering nutrition and transportation support to the drug-resistant TB patients and planning to include them in the National Health Insurance Program. We also plan to expand the social protection measures to the drug-sensitive TB patients, guided by the evidence from ongoing patient cost survey. To enforce political commitments towards ending TB, a high-level meeting in Nepal is planned in 2024. This gathering will bring together parliamentarians, government officials, civil society organizations, and healthcare professionals to discuss and strategize on achieving the UNHLM targets committed in 2023. This collaborative approach among multi-sectoral stakeholders will ensure shared ownership and accountability in the country's fight against the TB. On behalf of the government of Nepal, I reiterate our unwavering commitments to ending TB in Nepal by implementing evidence-based strategies, strengthening our healthcare system, and fostering collaboration across all sectors. We are confident in our ability to realize the ambitious goal outlined in the UN high level at achieving a TB-free future for the people of Nepal necessitates indispensable support and partnership from all stakeholders, including global leaders and global communities. We warmly welcome collaborative efforts to amplify our initiatives as we embark on a path towards a TB-free Nepal. Thank you.
We would like also to thank His Excellency Deputy Prime Minister for introduction of extremely important initiatives under his leadership and for bringing all the partners, including civil society, youth organizations together, working hand in hand with WHO. It's really excellent example. Now I would like to turn to the Honorable Mr. Sodnom Chinzonring, Minister of Health, Mongolia, to deliver his address.
Хүмүүндэт дэлхийн эрүүл мэндийн байгууллагын ерөнхий захирал доктор Тедрос Адханом Гебресус, дэлхийн сүрээгийн хөтөлбөрийн захирал доктор Тереза Касаю, эрүүл мэндийн сайд нар болон энэхүү сахин хэлцүүлэлт оролцож байгаа бүх хүмүүст энэ өдрийн мэндийг хүргэж байна. Та бүхэнд Монгол Улсын засгийн газрын нэрийн өмнөөс болон хувьсаа халуун мэдчилгээ дэвшүүлэхийн ялдамт сүрээтэй тэмцэх дэлхийн өдрийг тохиолдуулан сахин хэлцүүлгийг зохион байгуулж байгаа талархлаа илэрхийлж байна. Монгол Улсын Алсын хараа 2050 урт хугацааны хөгжлийн бодлого, Монгол Улсыг 2021-с 25 онд хөгжүүл 5 жилийн үндсэн чиглэл болон Монгол Улсын засгийн газрын 2020-с 2024 оны үйл ажиллагааны хөтөлбөрт сүрээгийн тохиолдлыг бууруулах, эрүүл идэвхтэй амьдралын хэв маягийг төлөвшүүлэх, халдварт өвчнөд тэмцэх, сэргийлэх арга хэмжээг хэрэгжүүлэх зорилтыг дэвшүүлсэн нь дэлхийн тогтвортой хөгжлийн зорилт 3-т заасан бүх нийтийн эрүүл мэндийн хамралтад хүрэх, дэлхийн эрүүл мэндийн байгууллагыг хэнийг ч орхитуулахгүй байх зарчим, хүн төвтэй эрүүл мэндийн тусламж үйлчилгээ, эрүүл мэндийн бодлогын зорилтыг хэрэгжүүлэх чиглэсэн төрийн томоохон арга хэмжээ юм а. Эдгээр бодлогын баримт бичиг сүрээгийн идэвхтэй илрүүлгийг нэмэгдүүлэх, сүрээгийн онцлогоо, эмчилгээнд сүүлийн үеийн тоног төхөөрөмж, онцлоор эмчилгээний шинэ гормыг нэвтрүүлэх, урьдчилсан сэргийлэх эмчилгээг өргөжүүлэх, эрдэм шинжилгээ судалгааны ажлыг өргөжүүлэх, тусламж үйлчилгээг ялгуурлан гадуурхалгүй тэгш сүрээд өссөн хүн амын хэрэгцээнд нийцсэн чанар хүртээ хэмжээг сайжруулах, санхүүжилтийг тогтвортой нэмэгдүүлэх, олон талт хамтын ажиллагааг нэн ялангуяа сүрээд өссөн хүн амын иргэний нийгэм болон төрийн бас байгууллагатай хамтран бэхжүүлэх чиглэлээр олон арга хэмжээ тусгагдсан. Монгол Улсын засгийн газрын сүрээгийн тусламж үйлчилгээний чанар хүртээ хэмжээг сайжруулах, нэгдсэн үндэсний байгууллагын сүрээг устгах тунхаг, дэлхийн эрүүл мэндийн байгууллагын сүрээг устгах стратеги болон зөвлөмжийг цаг алдалгүй хэрэгжүүлэлт анхаарч ажиллаж байна. Дэлхийн эрүүл мэндийн байгууллагын зөвлөмж болгож байгаа эмийн төсвөртэй сүрээг онцлох молекул биологийн Gen экспертийн шинжилгээг 2013 оноос үе шаттайгаар нэвтрүүлэн өнөөдөр Монгол улсын хэмжээнд нийт 42 лабораторид ашиглаж байна. Үүний үр дүнд сүрээгийн онцлогооны чадвар хөгжиж, тэр дундаа эмэн төсвөртэй сүрээг эрт илрүүлж оншийн баталгаа ажилд нэмэгдсэн байна. 2021 оноос Gen экспертийн шинжилгээний чанарын гадаад үнэлгээний хөтөлбөрийг улсын хэмжээнд амжилттай нэвтрүүлээд байна. 2023 оноос халдвар төвчин судлалын үндэсний төвийн сүрээгийн үндэсний лавлах лаборатори сүрээгийн үүсгэгчийн хэв шинж, эмэн төсвөртэй ялангуяа шинэ эмэн төсвөрчлөлтийг тогтоох халдвар дамжилт, дэгдэлтийг илрүүлэх сүүлийн үеийн геномын дараалал тогтоох дараа үеийн технологиг нэвтрүүлээд байна. Сүрээгийн бүртгэл, мэдээллийн системийн хөгжүүлэлт, шинжилтийг нийт 3 удаа хийж, тохиолдолд суурилсан бодит цаг хугацааны цахим системийг өнөөдрийн байдлаар бүх аймаг, дүүргүүд болон сүрээгийн үндэсний хөтөлбөр хэрэгжүүлдэг бүх нэгжүүд болох 34 эрүүл мэндийн байгууллагт ашиглаж байна. Цаашид сүрээгийн цахим системийн мэдээллийн өгөгдлийн үнэн зөв, бүрэн гүйцэд, цаг хугацаанд мэдээлэх зэрэг чанарын үзүүлэлтийг хангаж, аюулгүй ажиллагааг сайжруулахаар ажиллаж байна. Хиймэл оюун ухааны технологи сүрээгийн тусламж үйлчилгээг нэвтрүүлэх ажлыг 2022 оноос Монгол улсын нийслэл Улаанбаатар хотоос эхлүүлж, хиймэл оюун ухаанд суурилсан зөөрөн дижитал эрентийн аппарат өгөхийг гэрийн үйлчлэгийн баг гаргаж, хэвтрийн хөгжлийн бэрхшээлтэй, нэн ядуу, унааны мөнгө үгүй, сэтгцэн эмгэгтэй, өндөр настай зэрэг асрамжид байдаг, хурч очих боломжгүй эмзэг, эрсдэлт бүлэгт хурч үйлчлэх ажлыг өдөр тутам хийдэг болоод байна. Дэлхийн эрүүл мэндийн байгууллагын зөвлөмж болгож буй сүрээгийн эмчилгээний гормуудыг цаг алдалгүй нэвтрүүлж байна. Тухайлбал Монгол улс бүх эмийг ууж хэрэглэх гормын эмнэлэг зүйн туршилт судлааг амжилттай хийсэн цөөн орнуудын нэг болж чадсан. Дээрх нотлогоон тулгуурлан 2021 оноос бүх эмийг ууж хэрэглэх гормыг мэдрэг болон эмэн төсвөртэй сүрээгийн эмчилгээнд нэвтрүүлж, мөн урьдчилан сэргийлэх эмчилгээний шинэ гормуудыг хэрэгжиж эхэлсэн. 2021-с 2023 онд олон эмэн төсвөртэй сүрээгийн тохиолдлуудыг 9 сарын турш бүх эмийг ууж хэрэглэх гормоор амжилттай эмчилсэн байна. 2024 оны 1-р сард сүрээгийн тусламж үйлчилгээ журам заавар шинжилэн баталсан бөгөөд үүнд олон эмэн төсвөртэй сүрээгийн 6 сарын горим, эмэнд мэдрэг сүрээгийн хүүхдийн болон насан туршидтын 4 сарын горимуудыг шинээр оруулж баталсан. Эдгээр эмчилгээний горимуудыг энэ оноос эхлэн эмчилгээнд нэвтрүүлэх бүх бэлтгэл ажлыг ханган эхлүүлээд байна. Өнгөрсөн 2002 онд үндэсний хэмжээнд сүрээгийн ялгарлан гадуурхалтын үнэлгээг хийж, түүнээс гарсан зөвлөмжийг хэрэгжүүлэх, ялангуяа сүрээтэй үйлчлүүлэгч тэдний гэр бүлийг ялгарлан гадуурхалтаас ангид байхад хүний эрхийг дээдэлсэн тусламж үйлчлэгийг өргөжүүлэх чиглэлээр шинээр батлагдсан өдөртөмт зааварт оруулаад байна. Сүрээгийн улмаас ажлаа алдах, айл өрхийн орлого буурах, санхүүгийн дарамтанд өртөх байдлыг бууруулах чиглэлээр арга хэмжээ авч байна. Тухайлбал сүрээ өвчтний улмаас хөдөлмөрийн чадвар төр алдалтын тэтгэмжид 2023-нд нийт 2494 өвчтөн хамрагдсан байна. Сүрээгийн тусламж үйлчилгээнд зарцуулагдах төсвийн хэмжээ жил дотор нэмэгдэж 2023 онд улсын төсвөөс 22.3 тэрбум төгрөг зарцуулсан нь өмнөх оноос 10%-аар өссөн үзүүлэлттэй байна. Монгол улсад 2024 оны 1-р сард нийгмийн эрүүл мэндийн тусламж үйлчилгээний тухай хуулийг баталж энэ оны 4-р сараас мөрдөж эхлэх гэж байна. Хэдийгээр манай улсад сүрээгийн тусламж үйлчилгээнд дахиж дэвшил гарсаар байгаас тулгымцсан асуудал бас байсаар байна. Сүрээгийн илрүүлэлт буурсан хэвээр байна. Хэдийгээр илрүүлэлтийг нэмэгдүүлэх арга хэмжээ авч байгаас сар тахлын өмнөх үеийн хэмжээнд хараах нь хүрээгүй байна. Сүрээгийн чиглэлээр ажилтдаг хүний нөөцийн дутагдaltaч байсаар байна. Сүрээгийн тусламж үйлчилгээнд ялангуяа нийгмийн эрүүл мэндийн тусламж үйлчилгээний төсөв санхүүжилтийг нэмэгдүүлэх шаардлагач байсаар байна. 2024 онд тийм бид сүрээг устгах чадна хэмээн дэлхийн нийтээр сүрийн өвчнийг устгах амлалтаа биелүүлэхийг анхааруулж биднээс илүү ихийг хийж үтэх эрч хүч, шин санаашихтай ажиллахыг шаардж байгаа лээ. Монгол улсад сүүлийн жилүүдэд тохиогоогүй зудалтай хүнд өвлөд даван туулж байгаас эрүүл мэндийн тусламж үйлчилгээг тасалдуулахгүй чанартай үзүүлэхэд бүхий л талаар хүчин чармаалт гаргаж ажиллаж байна. Сүрээгүй, эрүүл, аюулгүй дэлхий болохын төлөө хамтдаа хичээцгээе. Анхаарал хандуулсанд баярлалаа. Захим хэлэлцүүлэгт амжилт хүсье. Баярлалаа.
We thank Honorable Minister of Health of Mongolia, and it's great to see this shift that happened over the past few years from just focus on finding missing people to the comprehensive response to the TB epidemic in the country. So it's really great movement, great shift, and we believe that it will help to accelerate progress. Now, I would like to turn to His Excellency Khalid Ait Taleb, Minister of Health Morocco, to share his message.
بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف المرسلين، السيد المدير العام لمنظمة الصحة العالمية، أصحاب السعادة، السيدات والسادة المشاركين. في البداية أود أن أعبر لكم عن سعادتي بالمشاركة في هذا البرنامج الحواري بمناسبة الاحتفال باليوم العالمي لمحاربة السل 2024، وأتقدم بالشكر الجزيل للسيد المدير العام دكتور تيدروس أدانون جبريسوس وكافة المنظمين. وأود أن أؤكد على الأهمية القصوى التي يكتسيها هذا الموضوع، ليس فقط بالنظر إلى الوضع الوبائي لمرض السل الذي يمثل تحديا حقيقيا للصحة العامة على المستوى العالمي، ولكن أيضا لتأثره الكبير بالمحددات الاقتصادية والاجتماعية. وفي المملكة المغربية لا يزال يشكل مرض السل مشكلة حقيقية للصحة العامة، وبالتالي يمثل إحدى أولويات السياسة الوطنية، خاصة تلك التي تنهجها وزارة الصحة والحماية الاجتماعية من خلال تنفيذ مخططات استراتيجية متتالية لمحاربة السل منذ سنة 2000. وفيما يخص الوضعية الوبائية، تقارب معدلات الإصابة بالسل في بلادنا حوالي 93 حالة جديدة لكل 100,000 نسمة، وتتسبب في وفاة ما يقرب 3000 شخص سنويا. ويسهر البرنامج الوطني لمكافحة السل على اكتشاف والتكفل بأكثر من 30,000 حالة سل سنويا بمعدل نجاح علاجي يبلغ حوالي 90%، و200 حالة فقط من حالة السل المقاومة للأدوية. إلا أنه من الواضح أن انخفاض معدلات الإصابة لا يزال بطيئا ولا يرقى إلى مستوى تطلعاتنا، حيث أن محددات المرض متعددة وترتبط بشكل أساسي بالظروف الاجتماعية والاقتصادية، وعليه فإن الإجراءات الواجب اتخاذها بهدف الحد بشكل كبير من انتشار المرض يجب أن تتجاوز المجال الطبي الصرف في إطار الجهود المشتركة للمصالح الوزارية المعنية والسلطات المحلية وكذا فعالية المجتمع المدني. نسجل بارتياح التقدم التي تم إحرازه في إطار تنزيل مخططين استراتيجيين الوطنيين السابقين لمكافحة السل، وأخص بالذكر توسيع نطاق عرض خدمات التشخيص والعلاج ليشمل كامل التراب الوطني، انطلاقا من مؤسسات الرعاية الصحية الأولية ووصولا إلى المستشفيات الجامعية، وكذا إشراك القطاع الخاص والمصالح الصحية للمؤسسات الأخرى. تحسين الترسانة التقنية للتشخيص المبكر بناء على الاختبارات الجزئية السريعة للتشخيص الأولي لكل من المرض والمقاومة المحتملة في آن واحد. وضع استراتيجية محددة للعلاج الوقائي لمرض السل لصالح الأشخاص المستهدفين، مع إيلاء اهتمام خاص للأطفال المخالطين المصابين بفيروس نقص المناعة البشري، واعتماد نظام العلاج الوقائي قصير الأمد. وأخيرا البدء مؤخرا بالتكفل بعدوى السل الكامن. علاوة على ذلك، طورت وزارة الصحة والحماية الاجتماعية نهجا متعدد القطاعات لتعبئة جميع الشركاء يقوم على أساس احترام مبادئ المساواة وحقوق الإنسان. وأمام هذا الزخم من التدخلات الوقائية والعلاجية والتربوية، استفادت وزارة الصحة والحماية الاجتماعية من التعاون متعدد القطاعات الذي نريد الآن تعزيزه وإرسائه في شكل إطار وطني للمسؤولية متعددة القطاعات بهدف العمل على المحددات الاجتماعية والاقتصادية لمرض السل. ومن هذا المنطلق يتجه المخطط الاستراتيجي الوطني الجديد للوقاية من مرض السل ومكافحته لفترة 2024-2030 إلى التقارب قدر الإمكان نحو الرؤية العالمية القضاء على السل بحلول سنة 2030، بما ينسجم مع التزامات بلادنا بتحقيق أهداف التنمية المستدامة التي تم التأكيد عليها خلال اعتماد الإعلانات السياسية الصادرة عن الجمعية العامة للأمم المتحدة سنة 2018 وكذا سنة 2023. ويهدف هذا المخطط الجديد بشكل أكثر دقة إلى الحد من الإصابة بمرض السل والوفيات المرتبطة به بنسبة 35% و60% على التوالي مقارنة بسنة 2015، فضلا عن تجنب التكاليف الكارثية المرتبطة بهذا المرض. ويتمحور المخطط حول 4 أهداف استراتيجية رئيسية يتعين تحقيقها بحلول سنة 2030، وهي كالتالي: الهدف الأول زيادة معدل اكتشاف حالات السل إلى أكثر من 95% ومعدل اكتشاف السل المقاوم للأدوية إلى أكثر من 75%. الهدف الثاني زيادة معدل النجاح العلاجي لمرض السل إلى 95% ومعدل نجاح علاج السل المقاوم للأدوية إلى 90%. الهدف الثالث ضمان العلاج الوقائي لمرض السل بنسبة 90% من الأشخاص المستهدفة. الهدف الرابع تحسين الحكامة وتعزيز آلية التنسيق والعمل متعدد القطاعات. أصحاب السعادة، السيدات والسادة المشاركين، وفي الأخير لا يفوتني أن أجدد عبارات شكري لمنظمي هذا الحدث الهام، وأن أتوجه بالتحية لجميع الشركاء في مجال مكافحة مرض السل على الصعيدين الوطني والدولي. والسلام عليكم ورحمة الله تعالى وبركاته.
We thank again Honorable Minister. It's great to see that introduction of a multi-sectoral approach and accountability into the practice, update of national strategic planning, and special thanks for putting strong focus on TB prevention and TB preventive treatment that will be discussed later today in the second session. Now we have today representative from different regions and countries with a different TB burden, and now I am pleased to give floor to Honorable Dr. Kalumbi Shangula, Minister of Health and Social Services, Republic of Namibia. African region is bearing the second highest burden of tuberculosis, and it would be important to hear about their actions and to drive TB agenda.
The government of the Republic of Namibia supports ending the global tuberculosis epidemic and upholds its commitment to the political declaration of the United Nations General Assembly high-level meeting on TB eradication. Despite having a population of just over 3 million, Namibia has a high TB burden, with an annual incidence rate of 450 per 100,000 population. Namibia has the 11th highest TB rate in the world. To help fulfill our commitments towards the 2023 political declarations, we have developed our 4th National Strategic Plan for TB using the People-Centered Framework, which will be launched during our National World TB Day commemorations. We have included TB as a key health priority in the National Development Plans and other strategic frameworks. We have established the Namibia Parliamentary Caucus on TB, in addition to other national platforms, working groups, and the Steering Committee on TB. We have commenced the process of updating all our guidelines to be more responsive to the requirements of the End TB strategy and to align with WHO recommendations and provide care at no cost to the affected citizens. We continue to prioritize our key and vulnerable populations, including those with special health needs. We have indeed seen an increase in TB cases owing to our renewed focus on case-finding strategies and closing the treatment gap, which has gone down from 42% to 25% in the last year. Namibia acknowledges the targets that we have to contribute from the 2023 United Nations high-level meeting, and we seem to be on track to achieving them. In 2023, for example, we have recorded 9,192 TB cases, which is at 7% above the target. 913 children with TB, which is 14% over the target. 300 and 11 drug-resistant TB cases, which is 19% over the targets. 2,096 children contact given TPT, which is 8% over the target. 4,963 older contacts given TPT, which is 5% above the target. And 8,268 people living with HIV given TPT. And for this last group, though, we are close to reaching the saturation, as most of our registered people living with HIV have already received TB preventive therapy. Challenges remains, however, for which we call on the global community to remain alert and responsive. We continue to be concerned about the constant threat of reduced international funding against the background of economic challenges in most developing countries. And we are still missing a significant number of TB cases, and reaching these last miles requires doubling of efforts and resources, which we may not have.
So, we thank Honorable Minister for the excellent update and fast move forward, because less than for 6 months they updated, they developed comprehensive national strategic plan and moving forward. This is exactly what we're expecting from the countries. Dear colleagues, now I would like to invite my close colleague, Dr. Rana Hajesh, Director of the Program Management from EMRO. She will represent also here WHO Regional Director, Dr. Hannah Balkny, to share with us on progress and challenges in the Eastern Mediterranean region to fast-track the TB response and key steps to reach targets. Rana, floor is yours.
Yes, good afternoon, Teresa. Can you hear me?
Yes, we can hear and see you clearly.
Our internet is not very stable. Thank you very much, and good afternoon, Excellencies, Dr. Tedros, colleagues. It's a pleasure to be with you at this meeting today, and I'm really happy to speak on behalf of Dr. Hanan, our regional director, who apologizes for not being here because of another travel commitment. It is very important that we gather today for the World TB Day, and we recommit to get back on track to end TB, which means intensifying our actions to reach the ambitious targets of the political declaration that came out of last year's UN General Assembly second high-level meeting on the fight against TB, which was already highlighted by many of the Excellency ministers. Following this declaration, it is our duty to reaffirm that we will all lead the way on implementing global, regional, and national strategies to strengthen the health systems needed and to ensure equitable access to health services, including TB. Therefore, in collaboration with all the international health and development agencies, governments, non-governmental organizations, private sector partners, academic institutions, and communities, we call for action on 3 important areas. First, it's very important for us to change our approach to TB prevention and to benefit from all the lessons we learned over the last few decades. Coverage of preventive treatment in our region is falling very short of targets, and the efforts to improve this situation in the Eastern Mediterranean region require increased attention and solutions that are adapted to our country's context. And with this specifically, I would like to emphasize the importance of the many countries in our region that are going through emergencies and conflicts that have weakened their health systems, but also that have led to specific conditions that make the situation with TB, whether it is diagnosing, screening, access to treatment much worse. Of course, I think the whole world is following what's happening in Gaza, in Sudan, where we have millions of people living in very, very crowded refugee camps. So risks of increased infection, as well as all the other factors that DG mentioned in his earlier comments, also with all the other malnutrition and the other conditions that weaken people's immune systems. So these need also a very special approach to better address TB prevention, as well as access to all medicines and treatments during emergencies. We encourage every country and territory in the region to take concrete steps to improve coverage of preventive treatment for eligible populations, including children in contact with TB patients and people living with HIV. Our region has pledged to increase coverage of TB preventive treatment to at least 2 million people by 2030, which is 60% of those who need it. And I think we can do better by 2030. We want to give these efforts the support they deserve. One of Dr. Hanan's flagship initiatives is the improvement of access to affordable medical commodities to secure equitable supply chains to help reach our targets, and TB is one of the diseases to be included. Second, countries need to allocate more domestic financial resources to end TB. In our region, again, less than half of the funding for national TB programs comes from domestic sources. We can do better. As a region, we are too dependent on donors. Hence, we urge countries and territories to develop sustainable domestic funding models and to work with donor organizations to secure funding for TB research, prevention, and treatment. Third, we need to accelerate action and ensure that every country and territory of the region adopts the latest WHO recommendations and guidelines so that the interventions are as effective as possible. WHO guidelines provide the roadmap. They are a roadmap, but we need to follow the map of implementation of these key interventions to ensure that resources are allocated efficiently and for maximum impact. Now is the moment to reaffirm our commitment and turn all of our words into useful actions, all of our pledges into progress, and all of our commitments into concrete results. Yes, we believe we can end TB together. Thank you. Over to you.
Thank you very much, Rana. We know that you are yourself, you're a passionate TB champion, and we're working hard to push this heavy agenda, especially in these exceptionally difficult circumstances, and we should all work together really to address these challenges. Thank you, Rana. Now we are pleased to welcome Mrs. Sherry Vincent, TB Division Chief for U.S. Agency for International Development, USAID. We know that USAID, the largest bilateral donors, and has been pivotal in accelerating global progress in the fight against TB. We are all looking ahead for translating commitments into concrete actions, and we would like to hear from USAID the latest news updates. We heard already some inspiring news, and also your vision how we can really put as fast as possible commitment into concrete actions. Sherry, floor is yours.
Great, thank you. And thank you to WHO for hosting this event. You know, every year we take this moment to reflect on the work that has been done and the achievements we've made in the last year, and to reflect on the lives that we have lost due to TB and the work that we still need to do. I particularly like to thank all of the colleagues that are online and have spoken today, particularly Dr. Tedros for giving us that direction of those three main points of the direction that WHO feels we all need to move forward on, and to Ashna for sharing her story. It's very powerful to hear, you know, what the communities and civil society are facing every day, what you need us all to do. And so I really appreciate that. As USAID, we are committed to ending TB. I will say up front, yes, we can, we have to. It's not just can, we must do this. We owe it to all of those that have suffered from TB and those who have not been diagnosed yet, that we need to quickly get diagnosed and cure. At USAID, Dr. Tul Gawande, who is our Assistant Administrator for Global Health at USAID, recently announced early, but we had an event here in Washington, D.C., progress on our UNGA TB HLM commitments. Within 6 months, we were able to announce for an initiative that we are leveraging additional resources. We all know that resources are not enough, and we need to come together to bring more resources to bear. And so announced that we are partnering with the government of the Philippines and the government of Ethiopia, as well as a private donor, John Green and his family, to bring more resources to those countries to really show how a comprehensive approach can tackle TB, and we can drive down incidence at a more rapid rate. So that's the first announcement. And there were additional $18 million that have been leveraged for that against USAID's $15 million in the first year. Also, we announced the rollout of our donation program for 3HP, which is a TB preventative therapy, as most of you know. And so following on the previous speaker, really looking at how can we roll out preventative therapy in children and household contacts, adult household contacts. So really looking at those 11 countries that we will rapidly roll out the 3HP and make sure that appropriate treatment is available. And the last is, we need to secure the proper commodities and to encourage new tools, but also the tools that we have, make sure that they're affordable and available and of good quality. And so we have selected a manufacturer in South Africa that will be able to produce the new processing for rifapentine, active pharmaceutical ingredient. I know that's complicated. We can give more information if anyone's interested. It's a very highly technical area, but we're really excited to bring that technology to South Africa and to this new company, and hope that it will improve access, quality, and affordability for preventative therapy. So we're doing all of this really in partnership with all of you on the line. We can't do it alone. We know that it's important to work with all the partners, including WHO, Stop TB Partnership, the Global Fund, and all of you there, and countries, and civil society and communities. So this is truly a partnership. We look forward to working with all of you because it's critical that we have to end TB. We definitely need to do this, and I hope we can do it in all of our lifetime. Thank you very much.
Sherry, thank you very much for sharing really inspiring, excellent news and showing example how commitment should be put on very concrete, ambitious actions and investments. I hope other donors and country leaders will follow this excellent example and invest more resources in TB response, and also accelerate their actions. This is indeed what we should do, and it's possible to end TB. Thank you very much for collaboration with WHO. Now, I would like to turn to other important partner. It was highlighted many times that tuberculosis is not just a medical problem. It's the socially significant area and problem that should be addressed only through multi-sectoral measures. We have a long-standing collaboration, excellent collaboration with IOM, and we are pleased to have today representatives from the new health director of IOM, Dr. Poonam Dhawan, with us. And it would be great also to hear from IOM. So what are the latest news and so plans how to address TB, working together with WHO and other partners and member states. We are pleased to have a statement from Ms. Ugoshi Daniels, Deputy Director General for Operations, International Organization for Migration.
Director General Tedros, Excellencies, distinguished guests. As we come together to mark World Tuberculosis Day, I'm pleased to join this commemoration, and I thank you all for your dedication as we strive to stop this global epidemic. I'd like to start by commending WHO on the release of the new investment case to help countries fight tuberculosis through high-level leadership, thus turning commitments into tangible actions. More than 2/3 of people with TB globally live in countries which have unique migration-related challenges, meaning that human mobility and equity for migrants cannot be ignored in the fight against TB. Unfortunately, about 1/3 of people with TB are still missed by health systems. This disease continues to threaten migrants, internally displaced people, refugees, and others living and working in vulnerable contexts. At the 2023 UN General Assembly, IOM welcomed the steps taken by member states to accelerate progress towards ending the TB epidemic by 2030, and the resulting political declaration, which recognizes migrants, refugees, and displaced persons' vulnerability to tuberculosis. Working with governments, national TB programs, WHO, the Global Fund, community organizations, and the private sector, IOM promotes access to TB screening, prevention, and treatment for migrants, improving their access to timely, regular, and healthy migration pathways. To promote people-centered, equitable access for all migrants, IOM has accelerated efforts on capacity development, advocacy, and integration of TB within our migration health strategy. The world is witnessing unprecedented levels of international migration and displacement. Scaling up measures to combat tuberculosis will require sustained funding, public-private sector partnerships, and solutions that look beyond the health sector. Together, yes, we can end TB. Thank you.
So another excellent statement and excellent collaboration to be continued. Dear colleagues, we have a really exceptional panel, and now from the biggest bilateral donor, from our important partners and UN agency, I would like to turn to the largest international donor representative, of Dr. Marijke Windrock, Head of Strategic Investments and Impact Division of the Global Fund. And we would like to ask you, Marijke, to share your perspective, hope to hear more positive and inspiring news from you. Marijke, floor is yours.
Thank you so much, Teresa, and also thank you for letting me speak before Lucika. It's always such a daunting task to follow her. And let me also start by saying that I'm fully supportive that we make TB Day into a TB week with lots of events the entire week. So really fantastic job, and thanks to all the inspiring speakers before me. Obviously, the Global Fund is the leading international funder of TB programs, providing 3/4 of all international external funding. So we are obviously fully committed to playing our part in achieving the goals set out by the UN High-Level Meeting on TB last September. Since the Global Fund was created in 2002, we have invested $9.5 billion in programs to prevent and treat TB, and obviously still counting. Allocations have increased over the years, and this cycle we're investing $4.2 billion over the 3-year period, which is just over $150 million higher than the previous cycle. And the focus is really on the countries with the highest disease burden, with TB priority countries, the 20 countries, an aggregate allocation of over $1.7 billion in this cycle, which also is an increase compared to the previous cycle. The TB community in our board has been very vocal that they don't only want the entire size of the pie of the Global Fund to increase, but also the share of funding for TB. And so we do have increased TB allocation this cycle, and I will be the first one to acknowledge that it's not enough. But we've also explored innovative financing options by leveraging funding from other sources to support TB and health system strengthening. For example, in India, Indonesia, and Pakistan, we have leveraged World Bank loans to increase the focus on TB in those loans. And this doesn't only generate more funding for TB, but also, as was the case in Indonesia, also allows us to engage in some of the broader health sector reform discussions that will be critical for the success of TB programs. Historically, there have been very few innovations in TB in treatment and diagnostics. And treatment and diagnostic options have remained unchanged for decades. I think Ashna referred to medieval therapies, and I think absolutely just a point there. Updated WHO guidance often took years to be implemented by countries, and when innovation became available, access often was slow and inequitable, which really has been a critical barrier in ending TB. Thankfully, this is changing now with a number of key technology and products entering the market space and a much more active and engaged TB community, both at the country, the regional, and the global level. Some of the recent innovations include the use of AI and digital chest X-rays to screen people at risk of TB. And further developments in these technologies will allow for chest X-rays to become portable, which will help us to access the hard-to-reach populations. And to increase detection rates, the Global Fund Partnership is investing heavily in the expansion of diagnostic molecular technology, which is a transformational approach that increases the speed and the accuracy of diagnosis of drug-resistant TB. We've also seen innovations in treatments with shorter and more effective and less harmful regimens for drug-resistant forms of TB and for TB preventive therapy. And we can hopefully leave behind the horrible regimens that Ashna was talking about. The Global Fund is working with countries to ensure that these innovations and improvements in TB care are introduced and implemented as fast as possible to make sure that people living with TB have access to the quality TB care that they deserve. At the same time, through our next-gen market-shaping approach, we're closely monitoring the innovation pipeline to support the acceleration of new products once they have received WHO guidance. When it comes to building resilient systems for health, the Global Fund Partnership is uniquely positioned to support countries to design and implement programs that fight the three diseases while at the same time expanding universal health coverage and preparing for future pandemics. We are the largest multilateral provider of grants to reinforce formal health systems and support community systems. Last cycle, we invested around $1.5 billion a year in formal and community health systems through our core grants and our CNAT-TNRM mechanism, which is about 1/3 of our total investments. The devastating impact of COVID-19 would have been much worse without the rapid and determined actions that took place across the Global Fund Partnership. Community health workers, laboratories, diagnostic equipment, disease surveillance systems, and other investments we made in the fight against TB in the last 2 decades played a pivotal role in the fight against the COVID-19 pandemic. The same system investments that help us to fight TB will reinforce pandemic preparedness, build resilience, and prepare the world for future health threats. Today, the work of the Global Fund Partnership is more important than ever. Increasing conflict and displacement, climate change, and the threat of new pandemics show that it takes a coordinated global approach to tackle global health threats. We can end TB if the new and reaffirmed commitments made at the second UN high-level meeting on TB are quickly translated into action. The Global Fund calls upon leaders to demonstrate strong political will, honor these commitments, and accelerate the TB response. With a focused response that fights for equity and puts people and communities most affected by TB at the center, this is our moment to end TB for good while preparing for future pandemics. Yes, we can end TB and wish you all a very happy International TB Week.
So thank you very much, Marijke, again, for sharing some good news and new commitments. We are looking forward to the new replenishment with hope. Again, we have ambitious targets and we need increased investments against these targets. And now we are moving to the next two exceptional guests, and I would like to start with Lucica Ditiu, Dr. Lucica Ditiu, a Romanian doctor, as she introduced herself, my good colleague and partner, and she is very busy. This time we see that she's flying from one part of the world to another, tirelessly working and advocating for TB. Lucica, please share with us latest news. So what is happening? What are your observations, if there are really inspiring movements to put commitments into concrete targets, and what Stop TB is planning to do to strengthen further advocacy, political leadership, and engagement of civil society and effective communities in TB response? Please, Lucica.
Thank you very much, Teresa. It's always great to be here, and it becomes a tradition. So now, you want or not, this gathering should happen every time. And I also add my voice, and I can say that last week in Manila, the people there asked as well that we don't have just a TB day, and people were not happy with the TB week. They wanted the TB month. And to be honest, there were 6 people, high level, who said it should be a TB year. So I said, okay, till we go to year, it will be great to have a month. And as you rightly said, the people started already doing events from, I think Pakistan was the first one, already on 4th of March. And I know that people will go till almost the end of March, even though this year there is an overlap with Catholic Easter. So it's great to see this enthusiasm. Now, Teresa and everybody here, this is very uplifting, and to hear the commitments and to hear the work and to hear the partnership. I think as our Ashna, our TB survivor, spoke about the fact that this is not a job of one, this is not the job of two, it's the job of everybody. And I think like a community, we should move forward shoulder to shoulder to be able to end this disease because it's feasible. From the Stop TB side, we will continue to push and support all the other efforts, because I think, and I want to have also a challenge for all of us, indeed, without people being aware about TB and the response, and when I say people, I say on the ground, normal people, like people, but also stakeholders, heads of states, heads of governments, different type of ministers, not just ministers of health. We really need to make sure that they understand their burden, they understand the TB response, they understand the needs and the gaps. So we will try to push forward of this type of dialogue as we had in Manila, but in general, in engaging and having conversations with all of them. I know that it's not like we won this, or we have a lot, but we have few presidents, as we know very well, that are leading on TB response, so we know for sure, or prime ministers, being India, being Indonesia, being Philippines, being, as we know, Kazakhstan, South Africa, Kenya, Tanzania, they are interested about the TB response, and we try to using their profiles. We announced the coalition of leaders last year in New York, and we will try to bring other presidents that doesn't necessarily need to come to a Stop TB or other partner event, but I think it's very important to take the ownership in the country. And I think it's very important that they speak about TB, that they create a lead in creating a movement, and ensure as well that there is a regular conversation that can happen at the country level. As a president or prime minister, you don't need to do much. You just need to say, can I understand where we stay with TB? And the wheels start moving. So we will continue to push this. We will start with few other countries in which we want the presidents or the prime ministers to get engaged, especially for the national level leadership. As you know, and I will end up here, we are working very hard in supporting the survivors, networks of survivors, or them individual, as well as different civil society organizations from developing or developed country, actually, to be supported and engaged in the TB response, and to take the place that they need to have, which is at the center of the effort. And it's not easy. And we are not doing this alone. Obviously, it's a partnership and everybody contributes. We are very happy because USAID is a very, I want to say something, a very clear, open-minded donor that understands the importance of the civil society and the functions that communities are having. So we are very happy because we were able to provide some funding for these organizations to get organized, as well as to increase the demand, to increase the awareness, to put pressure for increasing the domestic financing and so on. So we are working for that as well. And in 2024, and we hope to continue in 2025, the French government seems to come as well and support a little bit of this work, that we don't have any parts of the world untouched. So Francophone Africa to be on board at a very small scale, but still good. I want to say, to end with two things. This year will be important to show that people are committed, and you know that all these conversations that we have become a reality. One is because we have another UNHLM on antimicrobial resistance. I was very happy to see here His Excellency, the Ambassador of Poland in New York, and the coalition in New York. I am looking forward to this coalition to support a lot that TB is part of the political declaration on AMR. We are not there, as we know, never there, but I'm looking at this group to really push TB there. We are already discussing, but of course, it's not a conversation of stop TB or one or another. Together, we need to push if we want to be part of that declaration. That's the first challenge. The other one is, and I acknowledge very much Marika, what she said is this year are a lot of conversation around the Global Fund allocation for TB. This is not decided by Marika with Eliud and Peter Sands sitting in the room and deciding how big or small the cake it is. It's a decided decision done by the board. A lot of people in this call are represented in the board of the Global Fund, and a lot of them need to be informed and need to raise the voice if they really believe in what they said here. The honorable ministers that spoke here, they are part of different constituencies. I saw Morocco, I saw Namibia, I saw Nepal. Unbelievable good countries should raise their voice, and together we should have the conversation at the board of the Global Fund in increasing the pocket, or how to say, the global disease split for TB. Because, and I'm finishing here, yes, we can end TB. Yes, we will end TB. It's absolutely clear it is possible. The only thing that we miss are full funding for all these things that we have in the pipeline. Not only the tools and their rollout, the vaccine, So we need to secure these resources, because we saw that countries now have the ambition, are putting up strong proposal for the Global Fund. It will be really shame if after we raise the ball up, we are not able to hold it because money are missing, and we cannot accept that. So now, with the hands up, I'm telling you, yes, we can end TB. Thank you, and back to you, Teresa. Thank you.
Also, with my hands up, yes, we can end TB. Luchika, I can't agree more with your messages. Please keep moving, but take care. I've seen that you've already made chest X-ray, but nevertheless, take care. So we will need you on board for a long time. At least we should be all together till 2030 to continue push our fight. So thank you, Luchika. And now I would like to introduce our other very important guest. I assume that he is here at this talk show for the first time, but he may correct me. Dr. Tenu Afavia, Deputy Executive Director at UNITAID, our very good partner, working closely with us, shaping other part of TB response, other important agenda related to research and innovations and their uptake and their implementation into the practice. Dr. Tenu, please share your perspectives.
Great, thank you so much, Dr. Kasayeva, and colleagues, excellencies, friends. Good morning, good afternoon, good evening, depending on where you're dialing in from. And it is my first event or dialogue around the talk show, but I suspect there'll be others. So I have a daunting task of going after the always inspiring and dynamic Luchika, and I'm also the last speaker on what has been, I think, a very impressive panel. So my job is to try and be brief and leave you with a few take-home messages. Now, as many of you know, UNITAID was founded in 2006, and we have two main objectives in mind when we were funded. First was to work on incentivizing or to catalyze the development of missing health products for diseases such as tuberculosis. And let me add that TB was one of the very first disease areas that we started working in 2006. And second We work to ensure that when new treatments, diagnostics, prevention tools become available, they're optimally and quickly made available to patients, and that we break down the barriers that prevent their swift and efficient uptake by patients. So for us at Unitaid, in order to achieve those goals, partnerships have always been and will be at the center of our work. And every speaker literally has mentioned this. We very much value our partnership with WHO, which is also our institutional host. We also treasure our partnership with communities and with civil society organizations. And we are trying to walk the talk on this. So Unitaid has a board configuration of 13 seats on our executive board. One of those seats is occupied by community representatives, and a second seat is occupied by NGOs or civil society representatives. And that's very important to us because for us at Unitaid, we believe that our efforts have to be guided by those whom we serve, not just through meaningful and inclusive participation at the board level, but also to shape our investments, to co-create our interventions, and to ensure that we are meeting our commitments to communities and to civil society at the country level, and to hold us accountable to that. So for this year's World TB Day, as it approaches, and as many of the previous speakers have rightly done, they've referred to the commitments that we all made at last year's high-level meeting on TB. I want to go a little bit back from that, actually, and I want to recall the collective commitments we made under the 2030 Agenda for Sustainable Development, including ending TB by 2030. So I think we all remember the pledge that member states and the international community made to leave no one behind. But a less repeated, but for me, in the context of TB, as important pledge was also the commitment to reach those furthest behind first. And for us, what that translates to at Unitaid is working to address the clear inequalities that exist in our TB response. It also means that we'll be doubling down our efforts to make new health products for TB rapidly available to everybody, everywhere, especially the vulnerable and marginalized populations. And Unitaid being Unitaid, we plan to do this or focus on 3 priority areas. The first one is to catalyze more innovation. Now, we all know that one of the biggest challenges we face, or we continue to face, is the slow advancement of biomedical innovation for TB products, not least of all for diagnostics. And to try and address that challenge, we at Unitaid have made several investments to accelerate the development of diagnostics emerging from the innovation pipeline so that they can be used to help us find the missing millions of people who are living with active cases of TB and make sure that they're connected with the most appropriate treatment and care. So 2 areas we're focusing on more specifically is to advance the pipeline to accelerate the availability of better TB diagnostics for primary and community care settings, and then also to enable the use of the next generation sequencing for clinical decision-making and assignment of what could be the best treatment regimen, given the options available. So the first one is innovation. The second area that Unitaid will be doubling down on is our work on access. Now, in recent years, we focused a lot of our efforts on partnership, with many of you on the call here today, especially to make more effective, shorter treatment prevention therapy a reality. We've been successful working together with many partners to reduce or secure a price reduction of 70% for rifaximin. We have established a safe, quality, and effective sustainable generic supply. And we're accelerating uptake and wider availability for those most at risk. In addition to that, we have expanded our investments to support the scale-up efforts of new drug-resistant TB regimens to ensure that we are incorporating good stewardship of the drugs and the treatment into a development or to avoid further drug resistance. All to say that this work is being done to ensure that it's from a people-centered approach. And Asha reminded us that this is about not treating a disease, but about treating the person, and ultimately about improving quality of life. So the third area focus area that I want to hone in on, that we at United are redoubling our efforts, is to recall the commitments we made around reaching those furthest behind first. And for us, we have placed the priorities of marginalized populations at the heart of our TB response. The investments we've made have contributed to progress over the last decade in the development, the wide-scale introduction, and then also the rapid uptake of life-saving TB products for those furthest behind, especially children, adolescents, and pregnant women. We have been the leading multilateral funder of pediatric TB research for many years, and that has helped to launch correctly formulated TB medicines for children, which is extremely important. There's additional work taking place to make even better formulations that would be made available to treat children with drug-resistant TB and to prevent illness in children who have been exposed to drug-resistant TB. And finally, also our work has demonstrated, I think, some of the effective ways that we can integrate TB services into for children into community-led healthcare settings. So let me end by reiterating again for us at Unitate the centrality of partnerships to the work that we do, and to recommit to making sure that civil society and community leadership and engagement remains critical in driving our work, both on innovation as well as on access. And we look forward to working, I think, Luchika, you said shoulder to shoulder, with many of the partners on this call in the coming years. Thank you, and back to you, Teresa.
So thank you very much, Dr. Teno. Actually, you are not the last speaker. You are right in the middle of this talk show. Thank you for your important highlights and bringing concrete examples of the introduced innovations and access provided with the reduction of cost for the important interventions and for TB care services. Colleagues, at the end of this high-level important session, we would like to show you a glimpse of the activities ongoing in the countries over the past few weeks in the lead-up to World TB Day. And here are some impressive examples from Pakistan and Nepal. We are working, our WHO country offices are working closely with the countries, with the national TB programs, and organizing these activities to attract attention, to put spotlight, and to convince leadership. Okay, so this is the end of the session. Now we are moving to another one, which will be completely different. And you should prepare your notebooks, and I'm sure there will be important messages that you should fix and then later on uptake in your day-to-day work. This is about why we should invest in TB, not only highlighting the clinical aspects of the importance of addressing of the needs of affected people, but also responding to the questions of those who are planning, organizing, investing in healthcare and prioritizing different activities. We've tried to respond with our work together with partners why investments in TB screening and preventive treatment are important and impactful. And now I am pleased to hand over the reins to Dr. Denis Falzon, Team Lead for Prevention Research and Innovation of the WHO Global TB Program, to facilitate next session on the investment case.
Thank you very much, Dr. Kassaeva, and we are privileged at the end of this session to present to you some highlights from the investment case that was launched. I hope you had the chance to go through the brochure that was communicated already, and we will have the next speakers who will be looking at different aspects of this. So we will start with my colleague Saskia Demboon and our colleague from McGill University, Jonathan Campbell, who will give you insights into the main messages and the statistics behind them, following which there will be 3 countries that have participated in the exercise and to whom we are very grateful for the time that they have given. These are the Republic of Georgia, Kenya, and South Africa. They will present about what is the significance of the work they've done and the investment case for their advocacy efforts. And at the end, there will be a presentation tying up this to the 146 by 24 campaign of the Treatment Action Group by David Brannigan. So I start with inviting Saskia and Jonathan, who will in tandem make the presentation. The slides will be run one after the other so that we make the best use of time. Thank you very much. Over.
Thank you, Dennis. It's for me a pleasure and honor to be here to present today the work that we've been working on together as a real collaborative effort with 4 countries involved over the last year, I would say, and with Jonathan Campbell from McGill University, who is here as well. So we would like to officially present to you the Funding a Tuberculosis-Free Future, an investment case for screening and preventive treatment. So this figure is a figure that you may have seen before. This was developed before the launch of the NTB strategy, and it shows clearly that we both need to treat people with tuberculosis, but also people who are infected with tuberculosis mycobacterium, but who do not have active disease in order to reach the targets of the NTB strategy. So both TB treatment as well as TB preventive treatment are key in reaching the NTB strategy targets. This was already highlighted by previous speakers that there's about 3 million people with tuberculosis who did not access care in 2022. And often these are the more vulnerable people. We already heard about, for example, migrants. There can be people living in high-risk communities that are not treated. They're not accessing care for tuberculosis. With regard to TB preventive treatment, this is a intervention that we know works really well. People who receive TB preventive treatment have a reduced chance of getting tuberculosis. And since WHO started measuring in 2015, the number of people who've started TB preventive treatment has been increasing steadily. You see in this slide in yellow, people living with HIV, who've been always the majority of people accessing TB preventive treatment, but there's also now, especially last year, been a large increase in household contacts, also the household contacts over the age of 5 years who've been accessing TB preventive treatment. And last year, there was a total of 3.8 million people. Nonetheless, the targets that were set at the first UN high-level meeting on tuberculosis in 2018 were not met at the end of 2022. So the target was that 30 million people would be treated, but only just over half of the target was actually achieved. The only exception was in the subgroup of people living with HIV, where the target was more than achieved. But especially for household contacts, there was a large gap, as you can see on the slide here. But there are new opportunities. We have now shorter and safer treatments for TB preventive treatment, which should make it more feasible to roll it out at a larger scale and to reach more people. We also have new developments in the area of TB screening. For example, that was already several times mentioned today. We have now WHO recommendations for the use of artificial intelligence for computer-aided detection of tuberculosis. And together with new digital chest X-rays, like the portable digital chest X-ray system that you can see here on the slide, allows also for screening of tuberculosis to take place in more remote communities, closer to the people with TB, closer to the community. And finally, we also have the new antigen-based skin test to test for TB infection to target TB preventive treatment better. Last year in 2023, that the new UNHLM, there were new targets developed. These are very ambitious. These include to treat between 2023 and 2027, 45 million people with TB, including 4.5 million children and 1.5 million people with drug-resistant TB. The targets for TB preventive treatments are equally ambitious, with also a target of treating 45 million people, including 30 million household contacts of people with TB, including children, and 15 million people living with HIV. There's also a specific focus on reaching people in vulnerable situations, including those who live in remote geographical regions. So now we do have the political commitments to TB case detection and TB preventive treatment. We have the new tools available to make this feasible, and now we need to translate this into action on the ground. And this is one of the reasons why we developed this investment case. We really would like to use this to support countries in advocating for and allocating increased resources to scale up TB screening and preventive treatment towards reaching these new targets committed by heads of state at the 2023 UN high-level meeting. So with this introduction, I would like to hand over to Jonathan Campbell, who will take us through some of the methods that we used to develop this investment case and show the key results.
Thanks, Saskia. So we conducted this study in 4 countries, which were selected because of their distinct epidemiological characteristics. Brazil, a country with moderate TB incidence and moderate proportion of people with HIV who have TB. Georgia, a country with moderate TB incidence as well, but a large proportion of people with TB also having rifampin resistance. Kenya, a country with high TB incidence and large proportion of people with TB also with HIV. And South Africa, a country with very high TB incidence and majority of people with TB also with HIV. With the national TB programs in each country, we identified priority populations to scale up TB screening and preventive treatment. For all countries, people with HIV and household contacts were identified, but they also identified a high-risk population that might also benefit from scaled-up activities, particularly active case-finding interventions among groups that reach the WHO recommended TB prevalence threshold for this activity of 0.5% or more. This included people deprived of liberty in Brazil, people accessing care for injection drug use in Georgia, and people living in high TB prevalence communities in Kenya and South Africa. Next slide. We modeled distinct TB disease screening and TB preventive treatment strategies in each priority population, with testing and treatment algorithms developed in direct collaboration with national TB programs to follow both WHO recommendations, but also be feasible to implement in a short period of time. So these strategies were developed to be realistic to implement very soon. No new tests, nothing not available. We modeled scale of these strategies to reach target coverage levels indicated in the far right column by 2030 and projected impacts on cost and TB epidemiology from 2024 to 2050. You can interpret this table using the numbers under TB disease screening. The tests indicated with the same number mean that we modeled tests being done in parallel, while different numbers mean that tests are done sequentially, so only done in those who tested positive with the first test. The specific TB infection tests used and treatments used are indicated in the adjacent columns, all short 3-month regimens, all with the tuberculin skin test if testing is to be done. Among people with HIV, we modeled scaling up screening and preventive treatment to reach 90% of the eligible population, largely using symptom-based screening. Among household contacts, symptom and radiology-based strategies were used to reach 90% of contacts under 5 years of age and 50% of all household contacts 5 years or older. Among high-risk communities, we modeled 3 consecutive years of community-wide case finding that reached 60% of the eligible population at least 15 years of age. These activities were then stopped after 3 consecutive years. Next slide, please. So in brief, we developed mathematical models that were directly calibrated to tuberculosis epidemiology in each participating country that considered the impacts of post-TB consequences and disruptions caused by the COVID-19 pandemic. We estimated health system costs associated with TB-related activities in each country, which included hospitalizations, medications, outpatient care, tests and screening, as well as implementation costs and training that would be required to scale up activities. We also estimated the societal costs of tuberculosis, which included all health system costs, costs to those affected by TB, and then costs of lost productivity among those who lose their lives to this disease. All costs are in 2023 US dollars for comparative purposes. Next slide. So what do we find? We found that if we continued the status quo, that is what each country is currently doing with respect to TB screening and preventive treatment, 2.7 million people in Brazil, 42,000 in Georgia, 3.1 million in Kenya, and 4.3 million in South Africa would develop TB over the next 27 years. These episodes would equate to substantial years of life lost due to TB, 8.7 million years in Brazil, 109,000 years in Georgia, 17.8 million years in Kenya, and 24 million years in South Africa. Next slide, please. And the costs of allowing the status quo to continue are extreme, with very large costs to society. On average, tuberculosis results in annual cost to society of $3 billion US dollars in Brazil, 31 million in Georgia, $1.5 billion US dollars in Kenya, and 6.2 billion US dollars in South Africa. Again, these are societal costs per year, not over the full 27 years, per year, and often represent a significant proportion of country GDP. Next slide, please. However, we don't have to accept these consequences. We projected that scaling up already available technologies to a feasible to reach proportion of the populations targeted can avert a large proportion of TB episodes and deaths. In this graph, TB episodes are shown in solid bars and TB deaths in striped bars. The darker colors represent episodes and deaths averted due to TB screening alone, and the lighter color represents the additional benefit of layering on TB preventive treatment. You can see that screening alone has substantial impact, preventing 10 to 30% of all TB episodes and up to 50% of deaths in some contexts. The additional value of TB preventive treatment is clear, averting an additional 10 to 20% of TB episodes across varying epidemiological contexts. This is equivalent to hundreds of thousands of TB episodes prevented because of TPT. Next slide. And here's how the impact of these interventions look over time in each country. You can see large, consistent declines in all countries, ranging from 29 to 54% reductions in TB incidence by 2050. The top line represents the status quo in each of these graphs, and the bottom line represents the scenario with these interventions implemented. While the uncertainty intervals appear to overlap, it's important not to misinterpret these. All of these reductions are strongly statistically significant, equivalent again to 29 to 54% reductions in TB incidence. Among countries with high proportions of the population developing TB also with HIV, Brazil, Kenya, and South Africa, simply implementing screening and TPT among people with HIV leads to a reduction in TB incidence of 8 to 27%. So even targeted interventions in high-risk populations can lead to substantial declines in TB incidence. Next slide, please. So what will these large gains cost governments and health systems? It turns out that costs are modest at the end of the day. While the figures shown on this slide on the top half appear large, when you break down these costs on a per person per year basis, costs appear feasible, with costs ranging from 28 US cents to $1.11 US across participating countries. All of these health system investments are met with large societal returns, for which I will turn back to Saskia to discuss.
Thanks, Jonathan. So yeah, I'd like to show some results of the cost effectiveness analysis. This slide shows the incremental health system cost per TB episode averted. That's the light blue coins, and the cost per disability adjusted life year or DALY averted in the dark blue coins. And from the health system perspective, the cost per TB episode prevented are modest. And the cost per DALY averted, we compared them with country-specific conventional willingness to pay thresholds, and found also that that the cost per DALY averted were cost effective in all 4 countries. When we looked at this from a societal perspective, the intervention package was cost saving in all 4 countries. So when calculating the societal return on investment, we found that for each dollar invested in TB screening and TB preventive treatment, the country would get back between $4 and $29 in societal benefit. To be exact, the return on investment was $11 for each dollar invested in Brazil, $4 in Georgia, $27 in Kenya, and $39 in South Africa. So this was a scenario, as Jonathan explained, with already available tools at feasible levels of implementation. In a scenario analysis, we also modeled an enhanced package of interventions that was considered a bit more ambitious. This package had a larger coverage of the interventions and included shorter TB preventive treatment, namely 1 month of daily rifampicin and isoniazid, or 1HP, and also included the use of the new antigen-based skin test. We also considered the possibility that CAT might become available for chest X-ray screening of younger populations, and we modeled this too. This enhanced package achieved even more impact, with substantial numbers of additional TB episodes prevented in all 4 countries. So, in conclusion, we would like to share that TB screening plus TPT is a key investment in public health. It contributes to strengthening health services and providing universal health coverage. It's an essential intervention for progressing towards the NTB targets, and it addresses specifically needs of the poorest and most vulnerable populations. So TB screening plus TPT prevents TB in many people and saves lives. It's a very cost-effective intervention, and it leads to significant societal return on investments. So in order to fund the tuberculosis-free future, we do need to invest in TB screening plus TB preventive treatment. So thank you very much. Hand over back to Dennis.
Thank you very much, Saskia and Jonathan. I think these are some very interesting points and key elements that I think if you have time to look at these numbers in greater detail, you will be indeed impressed about the scale of the burden, right? If nothing is done, and also the cost effectiveness of these interventions that we are recommending here. Okay, so with this, we'll finish the first presentations, and we go over to the country panel. So unfortunately, Brazil could not be with us today, but we have the other 3 countries. So we'll start with Dr. Maka Danelia from Georgia. So Maka, the floor is yours.
Thank you. It is my pleasure to present today Georgia Country Insight Organ for the investment case. First slide, please. Every year, Georgia joins World TB Day campaign as an opportunity to raise awareness about TB-related challenges and solutions, and to support TB control efforts. We all recognize advances in TB control over the past decade and highlight the pressing need for strategies to reduce tuberculosis incidence and mortality, and not least strategies to reduce TB infection and risk of community transmission. In addition to the anti-TB strategy goals of reducing TB cases and deaths, an important aim is to protect families and society in general from the financial costs related to TB. With this approach, to substantially decrease the burden of TB, to end TB in the long term, and its impact over the overall social and economic development. Georgia has established comprehensive and fully functional national TB program, enabling 50% reduction of TB cases and achievement of high treatment success rate. However, as the figure on this slide shows, there is a good potential for improvement. Next slide, please. Georgia has used WHO tools to plan screening activities and TPT. However, this is the first effort to compare the enhanced package of interventions to the status quo and to estimate the epidemiologic impact as well as return on investment for scaling up tuberculosis screening and prevention. Many of the interventions of the investment case are not new. We have known for a long time that household contacts belong to the priority groups for active case finding efforts, and prevention is important. Novel technologies such as genetic testing end up quickly and to high levels. We have dramatically increased coverage with TPT. What this study shows is that we need to continue and increase our efforts along these upward trajectories. The findings also point at the need to precisely target activities related to screening and prevention in order to optimize the efficiency and impact. It is also not surprising that incremental health system cost per TB case or TB death averted is substantial. The country has already ensured full geographic and financial access to TB care, providing treatment coverage for the majority of cases, more than 70%. The missing cases belong to the hard-to-reach groups of population, so outreach and active case-finding efforts will be needed to target them. Such interventions are generally more expensive than routine services provided. However, to underline that these increases in health system spending were more than offset by the societal return of the investment package. Besides, new estimates from the investment case, as Jonathan mentioned, point that adding TPT to screening for TB disease maximizes health and saves many more lives. At the same time, incremental health system cost per capita decreases in the long term. Next slide, please. Ultimately, as any investment case in general, this study is essentially an advocacy tool. By presenting the full range of costs involved and full range of benefits that flow from these interventions, the study findings present an argument and have potential to influence decisions on investing in particular TB interventions for governments, first of all, Ministry of Health and Finance in Georgia, as well as donors. National TB program in Georgia is a model for public-private collaboration, engaging all relevant healthcare providers, so obtaining buy-in of private health enterprises will also be important. Government of Georgia has demonstrated commitment to fight TB that is reflected in the state budget, presenting the main funding source for TB care. At the same time, Georgia is the Global Fund recipient and interventions prioritized in funding applications should be well justified based on acknowledging needs and demand. They demonstrate the value of investment in monetary terms, and to the team that made this possible by reviewing the evidence, fashioning powerful tools to do the math, and creating relevant scenarios that are easy for this to understand and implement. In implementing the recommendations of the TB investment case for Georgia, we need and hope for everyone's help in making TB history. Investment case may be used as a tool to create support and consensus among stakeholders. These include, but not limited to, policymakers, health service providers, health professionals, and civil society. Let me repeat, yes, together we can end TB. Thank you.
Thank you very much, Maka, for that presentation. So we go to the next presentation, which is from Kenya. So Immaculate Katura was supposed to do this presentation. If there is someone else who is presenting on her behalf. If not, yes, yes, Immaculate.
I hope it can be heard.
Yes. Please go ahead.
All right. So I will be presenting on the investment case for TB screening and prevention for Kenya, and trying to underscore the significance and the importance of ensuring that TB prevention and screening is embedded into the very programmatic activities that we undertake, and to make sure that we can be able to scale up and accelerate these very important interventions. Next slide. So as a way of introduction, Kenya is a high TB and TB HIV burden country with a sustained increase in the number of TB cases experienced over the last few years. From previous catastrophic cost surveys, we realize that 27% of TB patients have suffered catastrophic costs from seeking TB services, with the impact being significantly felt more by those with drug-resistant TB, given the long duration of treatment that they have to go through and the expensive monitoring and follow-up tests that have to be done. In addition, the country has over the years seen a sustained domestic investment towards TB control, with up to 70% of our first-line drugs, for example, being procured using government resources. This, however, is not enough to be able to meet the needs of the TB control program, and significant gaps continue to remain to ensure that we can be able to meet all the resource needs required to successfully implement TB control activities in the country. Next slide. We also know that Kenya is among the few countries that have managed to achieve and surpass the 2020 End TB goals. Though the country has seen a commendable improvement following the COVID-19 setbacks, there is still a great need to increase investments towards TB and especially TB prevention efforts. Under the status quo, as mentioned, between the year 2024 and 2050, we project that up to 3 million people will develop TB, with almost 500,000 of them dying from tuberculosis over that particular period of time. In addition, the average annual cost to society for TB is estimated to be about 54 billion between the same period. And in that 2024 alone, 1.7% of the country's GDP will be consumed by TB. There is therefore need to identify high-impact interventions that significantly reduce the burden of TB, not just on the Kenyan population, but the economy as a whole. In addition, it is important for the decision makers and people that are in positions of authority, government leaders, and other investors to understand the economic impact of TB and the value that will be brought to the table by investing in TB screening and TB prevention jointly, so that then they will see the need and the value to continue to increase investments towards these two areas. Next slide. Prioritizing TB screening and TPT among priority populations will significantly reduce the economic burden of TB in Kenya. As had been mentioned, we have up to $580 million that could be saved in health system costs if we were to implement our TB prevention, in addition to our TB screening efforts. Further, we have about 416,000 TB episodes that could be averted, by including TB preventive therapy, and an additional 19, and this will prevent an additional 19% of TB episodes. 30,000 TB deaths could be avoided, bringing the total mortality reduction to up to 53% and setting the country well on its way to achieving the End TB targets. 1.3 million years of life would be saved by layering on prevention to the TB screening and making sure that the two strategies go hand in hand. In addition, we have seen that there will be significant savings and significant returns of investment for every dollar that is spent on TB disease screening and prevention in the basic package, with additional benefits if we add on additional layers of activities to that particular screening package. What this means is that the country stands to gain by increasing investments towards TB screening and TPT uptake. Next slide. So what does this investment case mean for Kenya? One, this particular investment case, as mentioned by the previous presenter from Georgia, is for us an advocacy tool. One of the things that countries, and Kenya specifically, has grappled with is the need to have targeted messages that are able to be understood, appreciated, and can be able to be targeted towards key decision makers, top government officials, and other persons that have investment resources that can be added onto the TB control kitty. The particular investment case for TB screening and prevention will be used to mobilize and sensitize TB stakeholders, including government, and to help them understand the impact of investing in the two strategies. And the government agencies that will be engaged will go beyond those within the Ministry of Health to include other sectors, given that TB is not just a health problem, but also has social determinants that can be drivers to this particular pandemic. And for Kenya specifically, realizing that those social determinants play a very significant role in driving the TB epidemic within the country. The other activity that will be looked at is to advocate, once they are sensitized on what the impact of this particular investment is, then to advocate for increased investments for both TB screening and TPT efforts at all levels of the healthcare, and specifically focusing our efforts at the community level, given that the country has invested heavily in scaling up the universal health coverage and the primary healthcare agenda. We will be leveraging on those investments to ensure that as much as possible, we are also ensuring they are covering investments towards or TB screening and TPT uptake are incorporated in those particular strategies as a way of realizing cost efficiencies and ensuring that we are targeting high impact interventions and communities where these particular vulnerable populations will be found. In addition, the message on increasing investments for TB screening and TPT will also be targeted towards private sector players that will be pivotal in increasing the resource basket that is going towards this particular investment. Thereafter, we will be doing what we call a TB screening and a TPT acceleration plan that helps us to be able to better target these investments as and when they become available, to make sure that the process has the maximum impact and, as mentioned, also leverages on other additional in-country investments for health. In addition, the acceleration plan will also seek to tap into the existing social health insurance that is currently being deployed or rolled out in the country that covers all sectors of the population, and especially those that are living below the poverty line that are most vulnerable for TB. Then thereafter, we will also be leveraging on the existing monitoring and mission processes to assess and review the impact of the investments for TB screening and prevention, and being able to adjust and amend accordingly as we go along to make sure that at the end of the day, we are responding to the needs of the country and to the shifting pandemic of TB within the country. But overall, as a whole, the investment case for TB screening and prevention will go a long way to help the country plan and scale up TB prevention efforts and be able to drive the country well on its way to end the TB pandemic. Thank you.
Thank you very much, Immaculate. A very clear and logical stepwise approach towards the use of the investment case. Okay, so with that, we come to the last country presentation. So I invite Dr. Lindiwe Mvusi from South Africa to present about the investment case for their country.
Thank you, and good afternoon, good morning, and good evening to everyone. I will just share briefly in terms of what our plans are in terms of taking these results forward, and to also indicate that we have been, this has been encouraging for us, because post-COVID, the momentum in terms of TB screening and TPT has been very low. So this is an opportunity for us to actually mobilize and advocate for scaling up this intervention and increasing resources to fund this. Next slide, please. What is particularly clear to us is that the status quo is not an option. As it has been indicated, we are not going to meet our targets on the TB incidence as well as the mortality targets. And what is even more concerning with the societal cost, particularly the cost to the patients and society, which we cannot allow to actually continue in this manner, particularly because we are currently facing high catastrophic costs for TB patients and their families at this point. And our strategy is to actually reduce that. And I think the other concern is mainly around the high cost generally of sustaining the status quo over the coming years. Next slide, please. In terms of what the impact of implementing to scale the TB screening and TPT, clearly it will assist us to move towards attaining the targets. And what is also interesting based on the results is that to hugely reduce the incidence and the mortality. But on the other hand, when you look at what it actually requires for us to do this, we find that the costs obviously will need to be explored further. But clearly what is clear here is that it is cost effective, and we probably need to then use that to sort of advocate for resources related to these interventions. And again, what is always a concern from our political principles as well as finance, which is treasury, is that we need to demonstrate the cost effectiveness and the impact of these interventions for them to actually fund them. The return on investment, one can really not dispute that, and I think it's another area that we will actually use to motivate for additional funds. Now, in terms of the number of TB cases prevented, I think for us, this much as we're seeing a reduction in the TB incidence, it actually over the coming years then shows us that if we do not necessarily invest in this, we are going to face an even higher epidemic down the years and treating people at even higher costs. Next slide, please. So in terms of what we are planning to do going forward, is that since we already are focusing on this, have identified some of the challenges related to screening and TPT. And in addition, we have also just released the revised TPT guidelines. We have within that identified who the high-risk groups are. And within that, I think what we probably need to do is identify, because the high-risk groups for TPT are clearly identified in the guidelines, but we need to identify specific populations that we are going to target with these interventions so that we have a more focused plan in terms of scaling up. Now, what we are currently planning to do is to scale up screening of priority groups for TB. And this includes the TB symptom screening, the digital chest x-rays with AI, as well as testing. The testing here is for the very same groups, which are people living with HIV mainly, household contacts, and as well as people who are living with silicosis. And these will be tested irrespective of TB symptoms. And also where the digital x-rays are available, we will use digital chest x-rays for those that do not have TB symptoms and try it those with abnormal chest x-rays to testing. What is new is that we haven't really done well in reaching all household contacts with screening and TPT. We've mainly been focusing on children less than 5 years. So we are going to start scaling up this intervention for all household contacts. And lastly, we also including the short regimens for treatment, currently looking at rifampicin and isoniazid for 3 months, as well as rifampicin and isoniazid for 3 months. We are not yet planning to move, at least within the coming 2 years, to the 1 month rifampicin and isoniazid, because we've just started scaling up the 3 months rifampicin and isoniazid. And there are lessons that we have learned in terms of health system, which needs to be strengthened, because without doing that, we're bound to fail when we go for the 1 month treatment option. And next slide, please. And what then this means is that we need to revisit the costing that was done for the NSP. And one advantage was that since this has been costed within the NSP, and this is a structure, this is coordinated by the CCM, which is a structure that is a multi-sectoral structure. We leverage on the different sectors that are within the SANAC to make sure that at least we get all the stakeholders to support this process. But when we look at the costing in the NSP, what we saw was that we probably did under budget for this intervention. And when I looked at what was estimated here at 207 billion, we only budgeted over the 5-year period for the strategic plan, only $44 million US. And we probably need to look at the shortfall or revisit the costing first, and then look at the shortfall and try and mobilize the resources to address the funding gap. And the other thing also related to this is that the challenge, one of the challenges actually that we've encountered with TPT and reaching household contacts is that we do not have coverage on outreach teams to actually conduct the outreach to households and community level. And this is part of health system strengthening component. And this is something we probably need to look at and see how then we make sure that for us to succeed with this implementation, we also try and strengthen and or maybe close the gaps where we have already identified that there are gaps. And the other area is what I term marketing of TPT specifically, because there's a lot of resistance in communities around prevention, and because people do not understand why they need to take medication to prevent a condition. So we're going to look at how we change our communication strategy to address this challenge, and also use social mobilization, strengthen social mobilization around this, engaged civil society. We have a very strong PLHIV civil society to assist us, particularly to increase demand at community level for TPT. And lastly, we'll also look at how we then monitor closely this intervention and identify barriers as we scale up. We also, during this, will use the opportunity that we're also looking at community-led monitoring to use that to also get the sense of how the communities feel and about this intervention, as well as how best we can increase the uptake, and also look at the supply side in terms of what are the issues and concerns from the communities. Otherwise, the other point was that as we scale up these interventions, we also, as we plan to also monitor for treatment outcomes, so that we understand how many, the proportion that actually completes treatment. We also need to strengthen the pharmacovigilance as we are introducing new drugs at scale, to understand as well in terms of what are the common adverse events that are reported. And that is the next slide. I think this is my last slide. Thank you.
And thanks to you, Lindiwe, for this great presentation. It's very good you raised this important challenge, right, about the reluctance at times from both healthcare workers and people who are at risk to use TPT, and the work that you're doing to try and reverse this problem. And I think the return on investment in South Africa with 1:39 is, I think, a very strong argument that that can be used, right, in advocacy efforts in the country. Just a small observation, because a lot of our data go to 2050, right, that we are presenting, but you can look at the estimates that go on to 2035 in a short sort of the shorter time frame, right, in the article that is linked to the brochure. And I think this is also, you will see that there are important gains to be made in the short term from these investments. So with that, I will come to the last presentation in this session, and I invite David to make his presentation. 5 minutes to you, David. Thanks.
Thanks very much. Hi, everyone. My name is David Brannigan. I'm the TB Project Officer at Treatment Action Group, and I'll be providing an update from the 146x24 campaign on delivering on the promise of new TB preventive treatments. Ending TB requires scaling up all the best available interventions, including TB screening and TB preventive treatment, as well as access to rapid diagnostic testing, universal drug susceptibility testing, and the best available shorter, safer regimens for treatment of drug-susceptible and drug-resistant TB. Models show that all of these interventions combined dramatically reduce TB incidence over time, as well as related suffering and death from TB. This new investment case for scaling up TB screening and TB preventive treatment is a call to action for governments and donors to increase funding for accelerated implementation of TB screening plus TB preventive treatment among people at risk of TB. These interventions are essential to make progress in closing the 30% TB diagnostic gap and preventing TB among the highest risk populations, including people living with HIV, child household contacts of people with TB, as well as household contacts of all ages. Scaling up these interventions requires significantly increased investment, not only in drugs and diagnostics, but in health systems. This is what the late Dr. Paul Farmer called the 5 S's. The staff, stuff, space, systems, and support necessary to deliver person-centered care and access to the best available tools to prevent, diagnose, and treat TB as a human right. The 146x24 campaign, launched in 2022, calls on governments and global health actors to take concrete action to put in place the 5 S's and scale up access to the best available WHO-recommended regimens by the end of 2024 as a human right. After more than 20 years of research and development, we can finally treat TB infection in as little as 1 month and most forms of drug-sensitive and drug-resistant TB in just 4 and 6 months. But relatively few people have access to these shorter, safer regimens. The 146x24 campaign aims to change that. This Friday, March 22nd, the 146x24 campaign is launching a mid-campaign report that details progress and gaps in scaling up access to the 146 regimens with specific recommendations for closing these gaps by the end of 2024. Next slide, please. As a result of scientific progress, we can now treat TB infection in as little as 1 month with 1 HP, or once weekly for 3 months with 3 HP. Between 2021 and 2022, there was a 3-fold increase in the number of people receiving rifamycin-based short-course TPT. and the number of countries offering these regimens increased from 52 to 74. But universal access to TPT is a long way away. 15.5 million people received TPT between 2018 and 2022, which is just over 50% of the target set by governments at the first United Nations high-level meeting on TB. And just 16% of those who received TPT in 2022 were provided with a shorter, safer one regimen. Data from the 2023 Global Fund concept notes also indicate that while nearly all high-burden countries intend to scale up 3HP during the grant cycle, implementation of 1HP remains much more limited. Due to a recent price reduction, 3HP now costs just $9.99 per treatment course, and the pediatric formulation of 3HP remains the cheapest TPT option for kids. Next slide. The 146 by 24 mid-campaign report that will be launched later this week spotlights the leadership of countries in scaling up access to the best available shorter, safer regimens. In Malawi, TB and HIV programs worked together to pilot 3HP with support from Impact for TB, and civil society proved instrumental in promoting the successful rollout of 3HP by raising awareness among communities to encourage uptake and adherence. In Zambia, stakeholder consultations and collaboration between HIV and TB programs was key to scaling up 1HP among household contacts, prisoners, and other key populations. The National TB Program actively solicited feedback from end users, which was overwhelmingly positive, and within 3 months, they had begun rolling out 1HP in additional regions. Investments in expanding access to TB screening and short-course TB preventive treatment is essential for making progress in the fight against TB. As we see from examples in Malawi and Zambia, it's also essential to center the experience of people affected by TB to inform and guide the development and rollout of TB interventions. We look forward to launching the 146 by 24 mid-campaign report on Friday, March 22nd, and to sharing more examples of country impact scaling up shorter, safer TB regimens, and recommendations for country governments and global health actors to take concrete action to close gaps in access to these regimens before the end of 2024. Thank you.
Thanks very much, David, for this, and very good. We look forward to the report on the midterm on your campaign. So with that, we finish this session, and I hand over to Dr. Kasaeva.
So thank you very much, Dennis. It was a very rich session, as well as the whole talk show. We are moving towards the end, but thank you very much for staying with us, for working with us, and for believing that, yes, we can end TB. Now, I'm pleased to invite Dr. Jérôme Salomon, Assistant Director General for the Universal Health Coverage, Communicable and Non-Communicable Diseases. He himself is a professor in infectious diseases, champions TB efforts with unwavering support. Dr. Jérôme would appreciate your closing of this important event.
Thank you. Thank you so much, dear Teresa. Honorable Ministers, distinguished participants, dear colleagues, friends, and partners. Today's discussions and dialogue at this important high-level event on tuberculosis have been inspiring and productive. As we look towards accelerating the TB response over the next 5 years, building on the commitments by world leaders at the 2023 United Nations high-level meeting on TB. As you heard, TB continues to claim millions of lives and causes suffering to those affected and their families. The experiences and work being undertaken by countries, partners, and civil society has been well showcased with a spotlight on innovations and multi-sectoral engagement. The need to ensure no one is left behind has been strongly highlighted, especially in the case of migrants and refugees, as the world grapples with unprecedented conflict and humanitarian crisis. We need to redouble efforts to ensure all people with TB access quality prevention and care in line with WHO's drive towards achieving universal health coverage. I would like to remind you of our top calls for action this year as I close. WHO is calling for high-level leadership and action to end TB. It's crucial to translate commitments made in the political declaration of the UN high-level meeting on TB into concrete actions, actively working towards achieving key targets by 2027. We are calling for increased investments in WHO-recommended TB treatments, diagnostics, prevention, care, and social protection that are crucial to save lives and reach TB targets faster. Financing for TB research must more than double to drive discovery of new tools, including vaccines, and to scale up life-saving innovations. The TB Vaccine Accelerator Council that we launched last year is an important platform for this. Linked to the previous points, we are placing a special focus on scaling up access to TB preventive treatment and screening services. The investment case launched today is a vital advocacy tool to help facilitate this. We are advocating for global action to address health inequalities and stigma for people with TB and other diseases. We need all sectors, all stakeholders, from ministries, partners, health workers, communities, and those affected, engaged and accountable. At WHO, we commit to invest in leading the end-TB response and keeping the promises made to the millions affected by TB each year, despite any hardships, challenges, or crises that come our way. We cannot falter in our commitment till we reach and save every person, family, and community impacted by this deadly disease. We call on you to join us in making investments of your time, energy, support, care, or financing towards ending TB. You can be a beacon of hope. Everyone has a role to play in ending TB: individuals, communities, civil society, youth, businesses, and governments. I would like to thank our eminent speakers and panelists and you, our wonderful audience, for joining us in keeping the spotlight on ending TB. We need to keep our promises. There is not a moment to lose. Let us join forces in prioritizing and investing to end one of the world's top infectious killers. Together, yes, we can end TB. Thank you very much.
So thank you, colleagues. And as we close, many thanks to Dr. Jerome for inspiring closing remarks. As we come to an end of this talk show, just to note that we had hoped to have an interactive session within. We've posted a link to a survey on the chat asking for your ideas and proposals on what action should be prioritized to accelerate the TB response. Many thanks to those of you who provided inputs already. We'll keep this link alive. Please do share your suggestions. We would appreciate it very much. So thank you very much.